Attendees are in listen-only mode.
Good afternoon, everyone, and welcome to MCPAP's Clinical Conversation for February. Our focus today is going to be managing anxiety in pediatric primary care. We want to welcome you to the fourth in our series of clinical conversations, all of which take place on the fourth Tuesday of each month from 12:15 to 1:15. A few housekeeping things I want to go over before we begin. This session will be recorded and available on the MCPAP website at www.mcpap.org. So please share that information with your colleagues and feel free to refer back to it. We will be taking questions at the end of the session. In order to ask questions, please either click on the raise hand button on your toolbar or write the question into the question box, and we'll be reading them, and Dr. Waslick will be answering them at the end of the presentation. We're saving plenty of time for questions and discussion. At the end of the presentation, when we're all done, you will each receive a very brief Survey Monkey following the presentation. We greatly appreciate your taking 2 minutes to just answer those couple of questions, providing your feedback. It helps us to improve future presentations. Thank you. So I'd like to introduce Dr. Bruce Waslick. Dr. Waslick received his medical degree from Tufts University School of Medicine and completed his residency at Tufts New England Medical Center. Dr. Waslick completed his fellowship in child and adolescent psychiatry at Columbia University College of Physicians and Surgeons. He is a child psychiatrist at Baystate Medical Center, and he is the medical director of the Baystate MCPAP team. Dr. Waslick has special research interests in randomized clinical trials, pediatric psychopharmacology, and mood disorders. Dr. Waslick, I'm going to turn it over to you right now.
Okay, great. Can everybody hear me? Hopefully, I'm online. So let's go to the next slide. I'll give the outline of the talk. So what I thought I would do would be start with a case and go into the case in detail, talk about some of the issues the kid was dealing with and also the family was dealing with. And this is a kid who presented to his primary care doctor with the problems that we're going to talk about. And so I'll give a full description of the case, and then we'll talk a little bit about anxiety in general, some classification ideas about how to think about anxiety and classify the different anxiety disorders. We'll talk a little bit about what causes anxiety problems and anxiety disorders. We'll go over some steps in terms of evaluation, which can be done at the primary care level, but also at the level of when to call in a more specialized practitioner. And then we'll talk about some basic elements of treatment, such as psychoeducation to the kids and families, some aspects of psychotherapy intervention, and then we'll also review medication treatments. And then we'll circle back to the case and specifically talk about the evaluation and the treatment recommendations for this boy, Jacob. So let's go to the next slide. So this is a boy who I saw in consultation about 6 weeks ago. We'll call him Jacob L. And he was a 12-year-old boy who was sent for a MCPAP consultation by his primary care provider. And a little bit of background history is that he did show some issues related to moderate separation anxiety during his first few years of schooling. So from kindergarten to second grade, parents reported that it was difficult for him to go to school. He didn't like going out in the morning. He didn't like being away from his parents. At times he would get distressed to the point where he would object to going to school. Sometimes he would complain in the morning that he was having some stomach aches or headaches. His mother was a stay-at-home mom, and he really liked being home with her. He was also showing some signs of difficulties at night, sleeping in his own bed, He had a lot of nighttime fears and worries, and would frequently either want to sleep with his parents, or after settling in and starting the night in his own room, he would get up and leave and then come in and try to sleep with his parents. The primary care doctor was aware of these concerns and had referred the family for counseling at that time, and they worked with a counselor over the course of about 12 months. The family learned a little bit about anxiety and a little bit about some parent management techniques to try to help them deal with Jacob and help him deal with his concerns about going to school in the morning. The parents implemented some behavioral interventions, and in that time there was some significant success. So the symptoms seemed to improve over the course of the 12 months of therapy. Truth be told, even from over the course of the next couple of years, Jacob still continued to present with a lot of worries. He was increasingly reactive to a stressful experience. Parents had basically, allowed him to miss school on occasion with some questionable somatic complaints. Nothing ever turned out to be medically serious. They weren't getting mental health interventions at the time because things were going relatively well. He was going to school, 95% of the days. He wasn't having severe dysfunction, but there were still some anxiety symptoms that were going on during the time. But the parents seemed to think that things were much better than they were in the first couple of years of school, and he wasn't missing a lot of school, and so they were overall pretty satisfied with how things were going. And then things really changed during the summer after he completed 5th grade. The parents' marriage fell apart, and the parents actually separated in the summer after Jacob's 5th grade year. And the father moved up to New Hampshire to relocate because of some of the difficulties with the finances that were a cause of and also a result of the separation. The mother decided that she had to return to full-time work, and there were some pressing financial issues, so she started working over the summer, and Jacob was spending more time with family members and professional daycare providers over the course of that summer. And there were some significant issues related to custody concerns. So over the course of the next few months, there were some significant legal proceedings related to the marriage and the separation and the pending divorce. And these were quite stressful to the family, and the parents were having a difficult time communicating with each other. They were pretty angry with each other and trying to negotiate things related to the custody. Next slide. So when Jacob started grade 6, it was clearly the most difficult of the school years. He started experiencing a lot more stress related to going to school. He didn't like school. He frequently told his mother, who he was spending most of his days with, that he was unhappy at school. He started fighting about doing homework. Mother had to now get out of the house to go to her work, and she was transporting Jacob to school. But Jacob would frequently complain of stomach aches in the morning before school. Even when he went to school in the first couple of months, Mother would frequently get calls from the school nurse that Jacob was feeling sick, and school nurse wanted to know what she should do, and none of the complaints really seemed to be that serious. They were mostly kind of nonspecific stomach aches, occasional headaches, but the calls were quite frequent. They were happening 2 or 3 times a week. On occasion, things would be so bad, or Jacob would be complaining so vociferously that Mother would actually have to go to school to pick him up. His school performance started deteriorating. He was having more isolation from his friends. He actually had been pretty social in grades 3 through 5, but now on weekends he didn't want to go out. He didn't want to spend time with his friends. He would not go on sleepovers with his friends. He didn't invite kids over. There were some increasing conflicts about getting schoolwork and homework done, and over the course of November and December, there were some significant issues related to school attendance. He was missing school. He was complaining that he was too sick to go to school. the initial separation agreement said that Jacob would spend 2 weekends with his father in New Hampshire in his new place, and Jacob started fighting about spending the overnights on the weekends with his father. There were conflicts. Mother would bring him to the meeting place with the father, and then Jacob would get frustrated, upset, refuse to go with his father, and eventually had to go home with his mother. And he also was having a lot of worries at the time. He was very worried about doing poorly on his grade at work and school. He started having thoughts, which was very unlike him, that the other kids didn't like him. They thought he was weird because he had to go to the nurse's office so often. He was missing school because he was sick. He also developed some fears that his mother was going to get hurt at her job. Even though she was in a very safe job, she was mainly doing office work. He developed some persistent fears that something bad was going to happen to her at work. And he also started worrying about his father's health. So that the father on one of the overnights had told Jacob that he was, he had been diagnosed with high blood pressure and he was taking a medication for it. Jacob started worrying that this was going to be a terrible illness, or that father was sicker than he was letting on, and he started worrying that father was going to develop a terrible medical illness, and became increasingly worried about those things. And things came to a head in December when he stated that he basically just couldn't go to school anymore. He started refusing. He got into physical altercations with his mother in terms of getting out of the house in the morning. He wanted to stay home. He was persistently complaining about stomach aches, headaches, all kinds of medical complaints. He demanded to his mother that she quit her job and that he wanted to be homeschooled. He didn't want to go to school anymore, but he thought that his mother could arrange so that he could get his schooling at home and that she would be with him at home. And he wanted basically his mom to quit her job to spend all the time schooling him at home. Next slide. So essentially, this evolved over the course of about three and a half weeks, and the tantrums were so severe and so upset that the mother was just beside herself, didn't know what to do. She was getting in trouble at work because she was, frequently coming in late and constantly getting calls when Jacob was actually in school. She would have to take time off from work if she couldn't get Jacob to school in the morning, and so she finally came to the primary care doctor for an evaluation for Jacob. Part of it was, is he really suffering from different kinds of medical issues, stomach aches, headaches, all the different medical complaints he complained about. And part of it was just, desperately hoping that something could be done because the situation was becoming unworkable at the home and big problems. The primary care doctor did a medical evaluation, good thorough medical evaluation. Nothing was found on the medical examination that would correlate with the type of medical symptoms that Jacob was complaining about. And the primary care doctor did think that there was certainly an emotional and behavioral component to what was going on. So the primary care doctor had consulted the MCPAP program, and we thought this was the kind of kid to bring in for an in-person evaluation. So that's the basics of Jacob, and we're going to circle back to Jacob at the end of this talk just to kind of talk about him in a little bit more detail and talk about a treatment intervention plan. But prior to doing that, I just wanted to orient folks to some key things when we think about anxiety. And one of the things I actually do a lot of is talk to parents and kids about the differences between fear and anxiety, and also talk a little bit about different ways to cope with fear and anxiety, and mostly from a psychoeducational perspective. So to start with fear, what I would call fear is a rational response to danger or threat. I usually give the example that if we open up the door and a big tiger is walking around out in our hallway, the tiger is clearly a danger to humans and is a threat, and that we're hardwired in many ways to deal with dangers or threats in a very adaptive way. So if we see a tiger or a dangerous animal out there, we're hardwired to have the fight or flight activation. So our eyes will open up, our pupils will react, our heart rate will go up. We're pumping more blood and oxygen to our brain and to our muscles. We're starting to breathe faster and deeper to get more oxygen again to our muscles, because we're all getting, in that situation, we're getting ready to either run away from the tiger or to fight off the tiger. So something is dangerous in our environment. Our physiology reacts in a way that's actually adaptive. Our central nervous system goes on alert to enhance our problem solving, and using all these sort of changes, it actually increases our ability to survive whatever threat is in our environment. And we also need to focus on accurate cognitive processing. What are the threats? What are the realistic opportunities to deal with this particular situation? And how do we cope? And that's all adaptive and very important for our survival as a species when we face real dangers in our environment. So I'd like to distinguish that. That's what I call the fight or flight activation, or a fear response, from what we think of in psychiatry as anxiety. So anxiety we consider more of an irrational response in the absence of a danger or threat, or that the person is perceiving something in a way that would make you think that they are in danger or in threat, but when you actually look at it, there is no real physical danger or threat to the individual in the situation. So I always give the example of like a phobia. Let's say I had a phobia of flying on an airplane. Airplane travel is the safest travel, around, and it's perfectly safe. But some people are phobic about flying on airplanes. So there's no real danger to them if they're flying on an airplane. In general, it's a very safe way to travel. But the individual with a phobia of flying on airplanes has perceived the danger. And the fight or flight activation is very similar in this situation, where you're perceiving a danger when there is none. And in that situation, the fight or flight activation is actually maladaptive. So it's making you feel uncomfortable, making you feel like you're in danger. You're getting all your CNS up on alert. Your muscles are tense. You're breathing fast. Your heart's going quickly, and there's no real danger in the environment. So none of that actually enhances your ability to cope with the situation. So in that situation, we could consider it maladaptive fight or flight activation. And that the CNS, when your central nervous system goes on alert in this situation, it's basically causing you a lot of unnecessary distress and impairing your ability to function. If you're very upset and feeling like there's a danger to going on the airplane, then you're likely not to want to go on the airplane. It's going to cause you too much distress. Your cognitive processing is also distorted and probably not functioning in the best way in that particular situation. And that's a funny thing, but the thing about it is that people can kind of perceive this from the outside and say, wow, you're getting so worked up about going on an airplane. It's so safe and it's such a good way to travel, but you're really feeling like it's dangerous. But from the inside, that person is terrified, just like they are dealing with a tiger walking around out in the hallway. They feel that there's a threat to their survival, to their physical integrity, that they are in danger, even though from the outside people are not kind of perceiving what's going on and where the danger actually is. So we also talk about coping with the anxiety. So I always talk to kids and families about common ways of dealing with anxiety when it's starting to get activated. And one of the most common ways of dealing with things is what we call avoidance. So avoiding it, especially if the situation that you're experiencing anxiety over is, it's a specific situation, or there's a specific triggering issue. One of the most common ways is basically to avoid it, to try to keep that particular experience that causes you to react in an anxious way. Try to keep it out of your consciousness, keep it out of your direct experience. And, it basically is a way of coping with anxiety. One way of that person coping with their phobia about getting on airplanes is just to avoid airplane travel. So, it's a sort of a natural way of coping. You just don't go on airplanes, and your fight or flight system does not get activated, and you keep control over that anxiety, by avoiding the situation. You don't travel on airplanes, you don't go across the country, you don't fly overseas, but your anxiety stays under control by using an avoidance strategy. Now, avoiding things that are dangerous to us is a very adaptive strategy, but coping with anxiety, especially the common anxieties that we see, using a primary avoidance strategy can be maladaptive. It can cause significant stress, it can cause significant dysfunction, and it's also been shown to actually increase the anxiety of the situation you're trying to avoid. So we talk about fear, anxiety, and avoidance just as basic sort of psychoeducational experiences. Next slide. So why is anxiety conserved in the human species? So, I think that's kind of led you in this direction. So a well-functioning fear and anxiety system, or a system of alert, can be very adaptive. It can be very helpful for you to deal with dangerous situations or threats in your environment. I liken it to a well-functioning pain system. So if you're experiencing pain because an organ is damaged, or you've got an injury, you need to rest it, or you're developing some sort of acute pathology in a particular area of your body, the pain can take your conscious resources and direct them to the source of the pain, and you can get attention for that particular problem, and that's very good. Similarly, anxiety increases alertness and causes the organism to shift attentional resources to cues in the environment indicating possible threats. This can be very helpful and adaptive and enhance the likelihood of survival when you're dealing with real physical threats in your environment. But just like a pain system that's telling you you have pain in areas of your body where there's no physical damage, there's no organ problems or injury, an out-of-control anxiety system that indicates danger or threat when in fact there is no danger or threat can lead to acute or chronic distress. It can lead to paralysis of decision-making, withdrawal, and dysfunction. And an out-of-control anxiety system, one that's no longer serving the individual in an adaptive way, is when we start thinking about anxiety disorder. Next slide. So I like to think of anxiety disorders in a couple of different ways. And so I've given sort of three big categories. One is what I call the stimulus-provoked or situational anxiety. And these are situations where the anxiety experience is often quite acute and very severe and feels like it's out of control, and it's regularly provoked by a particular stimulus. So this includes the phobias. So when I was talking about the phobia about flying on airplanes, this is an example of a stimulus-provoked or situational anxiety. Social phobia for many people is like this, so that you may not walk around sort of experiencing experiencing anxiety per se, but in particular situations such as being with a group of people that you don't know particularly well, or going to a social function where you're new to the situation, don't know the people particularly well, that can lead to what's called social anxiety disorder, where the anxiety symptoms get activated in social situations. Separation anxiety is similarly provoked in the sense that usually the stimulus for that is the individual being away from their trusted, identified parent for a period of time, and this could either be something that's imagined, or something real. So when kids go to sleepovers or go to sleepaway camp, it can be separation anxiety can be activated by those experiences. And then there are what are called stimulus unprovoked anxiety. Typically, we would think of this as panic disorder. Panic disorder is a series of panic attacks, and the panic attacks, for the most part, can't be traced to any known stimulus. So they tend to happen spontaneously. And then what happens to people with panic attacks is that they often develop a secondary anxiety where they're frequently worried that they're going to have another panic attack, which will put them in a situation where they're feeling out of control and this leads to the anxiety about having panic attacks and often increasing social isolation just to avoid having a panic attack out in public. Generalized anxiety is a very common anxiety disorder that we see in kids and adults, and this is kind of a hybrid. So the kids with generalized anxiety are kind of known worriers. They worry all the time. They tend to hear about something that's going on, like a disaster in a certain part of the country, and then worry that it's going to happen next door, and so they tend to magnify different threats in the world as being, even though it's very improbable that something bad was going to happen to them, they start feeling like it could be very likely to happen to them. And they can be set off, worsened symptoms can be set off by different sort of experiences in their immediate environment. So there's a generalized anxiety disorder component, which is chronic worrying, and then there's also the component of generalized anxiety where they tend to worry more about things that are in their immediate environment. So that's kind of a hybrid between stimulus-provoked and stimulus-unprovoked. And there's a couple of other major psychiatric disorders that we deal with kids where there's prominent anxiety, and actually they had previously been classified as anxiety disorders, but they really didn't fit because they have a whole different sort of etiology and a whole different symptom complex. I'm not going to spend a lot of time talking about these, but this would be the case of the traumatic disorders like post-traumatic stress disorder, where there's anxiety residual resulting from a previous traumatic experience, and then obsessive compulsive disorder, where the anxiety is usually around different types of obsessive thoughts that go on in somebody's head. So they're classified a little bit differently, but they often present significant components of anxiety. Next slide. So the etiology of anxiety disorders, I mean, there's clearly no one thing that tends to bring on anxiety disorders. Most of the cases you sort of evaluate, you're going to see multifactorial or complex etiological correlates. So at the individual level, certainly we know that anxiety disorders run in families to some extent. There are probably some genetic factors that are involved with giving somebody a diathesis toward experiencing anxiety at a pathological level. There has been a lot of work in the last couple of decades around fear circuitry. We probably have those kind of fight or flight circuits in the brain, which are adaptive and important in terms of our general functioning, but when we get aberrant fear circuitry tied to different sort of experiences and memories and coping skills, there probably are some brain correlates as well. There are certainly learning models so that if people are dealing with anxiety or dealing with different sort of experiences in a way that's particularly anxious or using sort of anxious thoughts or anxious ideas or modeling anxious behavior, kids will pick that up from people around them. There are different also models looking at cognitive processing and using different types of defense mechanisms. At the family level, again, we talked about the genetic diatheses that run the family, the coping style, so that when people are prone to anxiety, how they cope with it. We talked about the avoidance, using avoidance as a primary coping set of skills. Other families tend to use what's called face your fears, or throwing yourself into the experience a little bit more as a coping style. So kids will develop different coping styles modeled by different people in the family. At times, different types of family dysfunction can lead to maladaptive coping, and the overlay of trauma certainly can make things worse for kids who are already prone to anxiety experience. And there's other environmental factors as well, such as kids living in dangerous environments where they experience a lot of different sort of traumas and different types of educational issues. Next slide. So at the primary care doctor level, I mean, in terms of assessment of anxiety disorders, you really want to take a comprehensive history in the time that you have allowed. I think it's a good idea for a medical provider, if you're the first person to come in contact with a kid who's complaining of significant anxiety symptoms, certainly do a comprehensive medical evaluation and physical examination, which would be standard. Make sure that there aren't any other medical factors that are going on that might be worsening the kid's stress level or presentation. A lot of kids who are presenting with anxiety complain of somatic problems, and sometimes it's difficult to sort out, is the anxiety, causally connected to the somatic complaints? Is the fact that kids are having medical problems increasing their stress and causing more in the way of anxiety? So sorting that out through a comprehensive medical evaluation and physical examination, and any specialized testing as needed. And I also sort of recommend that, once you've done your evaluation, to make sure you're clear with the family about the results of the medical evaluation. So if the kid's complaining of a lot of stomach aches, and you've done an evaluation, and you don't think there really is anything going on acutely in the gastrointestinal system, be clear about that. It doesn't look like we have a clear medical etiology for this, but we also know that anxiety at times, and depression as well, can lead to the experience of different types of somatic concerns, like stomach aches and headaches and things like that. And so, be clear about the results of the medical evaluation, and sometimes put in that different types of psychological factors can lead people to experience distress in their different physical symptoms as well. Next slide. I think it's important to educate people about anxiety disorders, that they're generally not life-threatening. There are some correlates, a small percentage of people experiencing anxiety can get to the point where they have suicidal ideation and suicide attempts, but in general, anxiety and anxiety disorders are not necessarily life-threatening, but they certainly can lead to serious levels of distress and dysfunction if not recognized and addressed appropriately. You can see in the case of Jacob L., if he continues to avoid school and decides that he can't deal with school and wants to be home, his whole educational experience could be affected in the long run if that's his primary coping mechanism, and that continues for the next 2 years. It's important to let people know that effective treatments of anxiety are available, and that we have significant evidence that the available treatments are both effective and safe. And also that families have some flexibility in terms of different treatment options. The one option we wouldn't choose and wouldn't recommend is to do nothing, because usually when you get to the level of experiencing a significant anxiety disorder, just doing nothing is usually going to lead to worsening distress and worsening impairment. So the option of doing nothing usually is not a real good option for families. But there are other options, so that talk therapy, psychotherapy can be an option for some kids. There are medications that are available that can be very effective in helping tone down the symptoms of anxiety and help kids feel better. And then the best treatment option that's supported by evidence is a combination of talk therapy and medication therapy. Next slide. So psychotherapy, for people who know that there's a variety of approaches that are available. Most of the available psychotherapies will offer education about anxiety and support, so that let the kids know they're not the only kids who've ever dealt with an anxiety or severe anxiety problem, and that our goal is to try to help them with the different problems they're experiencing. There are some approaches using expressive therapy, get kids to talk about their problems, get them to understand how anxiety is affecting their experience and their functioning in the world. They're functioning with their families, they're functioning with their friends, they're functioning in school and all their activities. There are psychodynamic approaches, psychoanalytic therapy, and I'm not going to spend any time on those, but I do want to make sure people are aware that the best evidence-based psychotherapy option is what's called cognitive behavior therapy. And cognitive behavior therapy I'll describe in a little bit more detail. Usually starts with, again, psychoeducation, making sure the kids and the families know what anxiety is and how it's affecting them, and learning to be able to recognize the experience of anxiety and how it's affecting their decision making. It usually includes skill building, helping kids develop different skills and different tools to cope with their anxiety. And some of those are physical things they can do to help decrease their experience of anxiety. Sometimes it's different cognitive skills, different ways of reframing anxiety and anxious thoughts. But the hallmark of cognitive behavior therapy is exposure therapy. Exposure means that, especially in the situations where there's a stimulus-provoked anxiety, is that kids are going to learn the skills to be able to cope with those stimuli that bring on the anxiety, and as part of the therapy down the road, once they have the skills to be able to deal with it, they're going to be exposed to the things that make them anxious. So for somebody who's got an airplane phobia, the ultimate goal is not to talk about it in therapy. It's that the individual is going to get on the airplane and take a trip and bring to bear all the skills they've learned to manage that experience. For a kid with social phobia, it's going to be going out and spending time with kids they don't know in group situations. And the concept of that is, this works for most people with anxiety, is that for adequate exposure to an anxiety-inducing stimulus will ultimately lead to the reduction of the anxiety symptoms. The more somebody puts themselves in the situation where that activates their anxiety and brings to bear the skills and coping mechanisms that they've learned in therapy, the less the anxiety is going to have a hold of them, and the better they're going to be able to cope with the anxiety. So that's exposure-based therapy. It's at the end of the day, you're going to expose yourself to the thing that makes you nervous, and you're going to deal with it successfully. And the more you do that, the less the anxiety is going to have a hold on your decision making. Next slide. Of course, we also think about medication. So there are a couple of different medication approaches. The first is for acute symptomatic treatment as needed. I, as a child psychiatrist, I tend to favor the use of things like antihistamines, Vistaril or Benadryl, for this kind of as-needed PRN for acute coping with acute anxiety. I prefer that to the benzodiazepines because the benzodiazepines are obviously controlled substances and have the tendency or have a possibility of being misused or abused. And there's been actually some research evidence that suggests that it doesn't necessarily matter what the pharmacology is for these kind of acute situations. It's just having some tools as a coping tool to deal with severe anxiety. And I think the antihistamines work pretty well. Some people use or recommend propranolol or other types of beta blockers for acute performance anxiety or certain situations where they're going to be exposed to something that they're phobic about. And propranolol really helps with some of the physiological experience of anxiety, such as rapid heart beating and blood pressure changes. And then we also think about the longer treatment with medication. And the treatment of choice for anxiety for longer-term treatment really are the antidepressants. We usually recommend a serotonin-specific reuptake inhibitor, and I'm going to show you a table of the medicines that we tend to recommend in their usages and their dosing. But there actually is an SNRI that's FDA approved for use with kids with generalized anxiety, and that's the SNRI duloxetine. Some people have recommended tricyclics. We don't use much. We usually don't use tricyclics at this point, primarily because of their side effects, but there actually is some literature suggesting that tricyclics like imipramine is historically helpful for kids with anxiety problems. Benzodiazepines, I have a few kids who are on benzodiazepines. I don't use them very readily. There are certain situations where I do use them, and I have to know that the kids are not going to misuse or divert the medications. And usually in a situation where the treatment with antidepressants has not been helpful or not well tolerated. So there are particular situations where I will consider benzodiazepines, but as a practicing child psychiatrist, I don't use them very much with kids and with teenagers. And then there are some other agents that are studied for treatment and for use in treatment refractory cases. Some of the anticonvulsants, some atypical antipsychotics. That's much more specialized care, and I don't think you would probably do that on your own as a primary care doctor. But there are some uses which are considered reasonable for cases of treatment refractory anxiety. Next slide. So here's a slide of the first-line medications for pediatric anxiety disorders, and I put up mostly SSRIs and one SNRI. The reason I put up the SNRI is because duloxetine is FDA approved at this point for treatment of generalized anxiety disorder in kids. But the other medications, citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, sertraline, all standard SSRIs. Some of them are FDA approved for the treatment of major depression, like fluoxetine in ages 8 and up, and escitalopram or Lexapro in ages 12 and up. Some of them are approved for the treatment of OCD, obsessive compulsive disorder, in kids down to the age of 6 for sertraline, 7 and above for fluoxetine, and 8 and above for fluvoxamine. And you can see from the dosing, we tend to recommend starting lower doses with kids than we would with adults. So I'm pretty conservative in my starting doses. I do have some ideas about the general therapeutic dose, but one of the important things, especially when you're dealing with anxiety, is that the kids don't experience bad side effects, because that will trigger more anxiety and distrust of medications. So if you want to give kids a good trial of medication, I would favor and argue for starting low and trying to avoid side effects initially, as opposed to being very aggressive. Next slide. Again, I don't use a lot of benzodiazepines, but if I do use them, I tend to favor one short-acting medication, one short-acting benzodiazepine, lorazepam, and again, very conservative dosing. And if I need something which I think is needed for more long-acting medication or more chronic treatment of anxiety disorders, I would tend to favor clonazepam at this point. Again, conservative dosing and really, shooting for the lowest effective dose, which would be unlikely to cause any kind of side effects. The other medication, I generally don't prescribe Xanax. I haven't prescribed Valium in probably 2 decades. But if I do prescribe a benzodiazepine, it would be most likely lorazepam or clonazepam. Next slide. And just some treatment tips. Best medication for serious anxiety disorders, and this is evidence-supported, include a combination of medication plus psychotherapy. And if I was going to be more specific, I would say SSRI medication plus cognitive behavior therapy, including exposure-based interventions. We think of treatment in phases. So the first phase is really acute symptom control. If kids are really doing well with the acute phase, we usually recommend a maintenance phase where they continue in treatment, ongoing treatment with medication, ongoing sessions with their therapist to make sure we consolidate the gains of the acute phase and help the kids function in that maintenance phase. Once kids are really doing well, we can start thinking about prevention of recurrence after they've been relatively symptom-free and they've been functioning better. And eventually, we hope that all kids will be able to come off active treatment, taper off the medication, reduce the frequency of sessions. And if we successfully get kids off medication, I actually try to monitor the kids off treatment just to kind of make sure that things are going to go okay and be vigilant for recurrent episodes of the severe anxiety. And in general, medication treatment is generally safe and effective, but not everybody responds. Next slide. Treatment has to be individualized, but can be reasonably expected to follow some general guidelines. So again, a general guideline would be, using SSRIs as a first-line treatment for anxiety, but it could be individualized in terms of the selection of the particular SSRI that you're going to be choosing. In terms of major risks of medications, with the benzodiazepines, the big one is obviously sedation in the short run, but misuse and addiction in the long run. The antidepressants have complex side effect profiles, but generally I'd say, but people should be, I'm sure, aware of the black box warning for antidepressant use in youth applies equally to the treatment of anxiety disorders and mood disorders. So some people have said, well, the black box warning is for fluoxetine is really only about kids who are depressed. Well, actually, the research would suggest that the particular disorder you're treating with antidepressants is not very predictive of this infrequent issue related to treatment-emergent suicidality, which is the black box warning. So you have to be vigilant about the experience of suicidality, whether you're treating mood disorders or anxiety disorders. Next slide. So just circling back to Jacob, this is the boy we talked about at the beginning. So as part of the consultation, I did the review of the history, the medical workup, and discussion of the issues with mother and Jacob. Mother attended the appointment. We did a good mental status examination. I had mother and Jacob complete the SCARED rating scale for anxiety. SCARED is one that we tend to favor as a rating scale because it helps break down the different types of anxiety and gives you pretty good, clear-cut levels at which the kid is experiencing anxiety, which is no longer in the normal range, both in terms of all the anxiety symptoms as well as the individual anxiety disorders. And when we looked at the SCARED ratings for mother and Jacob, they were both markedly positive as both rated themselves. The factor scores were prominent for somatic issues, separation anxiety, and generalized anxiety. We ended up giving them the DSM-5 diagnosis. We ended up giving Jacob the DSM-5 diagnosis of generalized anxiety disorder and separation anxiety disorder. Next slide. In terms of a treatment plan, we talked about anxiety, coping with anxiety, and that Jacob was engaging in a lot of avoidance behavior as his primary means for coping with the anxiety that was being set off by going to school. We did a little bit of counseling to say that using avoidance to deal with the anxiety tends to make the anxiety symptoms and the level of dysfunction worse, and that we informed them that we thought that anxiety was controlling Jacob's behavior and decision-making instead of Jacob, because we knew that Jacob actually valued going to school, getting his education, but the anxiety seemed to be controlling his decision-making. Now, this is a boy who was at a severe level of dysfunction, and the anxiety was really part of his difficulties, and he was at severe dysfunction. So we made the suggestion for referral to our child partial hospital program because he needed an intensive intervention to help him develop coping skills and reduce the level of anxiety. Otherwise, we thought that his symptoms were going to get worse and his dysfunction was going to get worse. So we made a referral to our partial hospital program. The partial hospital program ended up using different types of CBT principles during his 2-week stay there. We recommended the primary care doctor begin treatment with fluoxetine, beginning at a dose of 5 milligrams per day and advancing as tolerated on a weekly to bi-weekly basis to a targeted dose of 20 milligrams. Again, that was as tolerated. And we also recommended Vistaril as a rescue recommendation for the severe acute anxiety to see if that would be helpful for Jacob as a coping tool for the times when the anxiety was at its most severe, until the fluoxetine was at a level where it was providing significant longer-term benefit. Next slide. So actually, Jacob did pretty well with that treatment plan, and he's functioning much better at this point. He's on fluoxetine 20 milligrams per day. He did a good job in the partial hospital program. He's been referred to a cognitive behavior therapist in the area, and the mother's been able to go back to work, and Jacob has been able to return to school. Still occasionally gets activated in terms of his anxiety, but overall he was treated very effectively, and his primary care doctor is managing his medication at this point. So that concludes the presentation, and happy to entertain any comments or questions at this point.
Great. Thank you, Dr. Waslick. We're going to take questions again. The best way to pose a question is to type it into the question box or to click the raise hand tool on the toolbox. We have one question. I'm going to unmute Nancy Langans. Would you like to ask your question, please? No? Nancy? Okay, let's see if we have some other questions. Yep, we do. Here we go. The first question is, the black box warning for SSRIs is for increased suicidal ideation, not increased rate of successful or attempted suicide. Is that correct?
It's partially correct. So the warning is about treatment-emergent suicidality. And when you looked at the data, this was a compilation of a lot of different randomized controlled trials. And it is completely true that in that meta-analysis of the randomized controlled trials, there were no completed suicides in any of the trials. But there were both suicidal ideation crises as well as suicidal behavior. So it does include anything related to treatment-emergent suicidality, both thoughts as well as behavior. But the meta-analysis looking at this did not have any completed suicides.
Great, thank you. The next question is, I appreciate starting at low doses and most parents want no medication. How slowly or quickly can you safely increase the dosing in general without worrying parents about using too much but getting to an effective dose as soon as is safely possible?
So I keep in mind, you know, the targeted medication. So like, for example, with fluoxetine, I know that the studies of fluoxetine for kids, so we have some evidence here, suggest that in general, on average, the therapeutic dose is 20 milligrams per day. I always think of it as a range, too. So some kids do well on lower doses, some kids need higher doses. My general strategy is to educate before we start treatment what I think the general dose that we're going to be shooting for, and to start with low doses, primarily because, especially when you're dealing with anxiety, side effects really get people worried. So if a kid develops severe nausea or vomiting at, you start at 20 milligrams and you could have avoided that by starting at 5 and working your way up by 20 milligrams, I think that's time well taken, because the usual sort of time frame for seeing benefits from the medication is over the course of about 4 to 8 weeks. So you have to get the medicine in the kids. You got to get them to tolerate it, be compliant with it, and then the eventual benefits will evolve over time. So I usually sort of recommend sort of a suggested average dose, a dose range, and start low and increase the dose usually on a weekly to bi-weekly basis. And I usually also sort of say, let's increase the dose on weekends while they're under your observation so you can know whether they're tolerating that dose increase before they go off to school. So those are different strategies to deal with that. But I agree with the general idea that sometimes when you got people who are really worried about medication, you can be at risk for undertreating and never getting to an effective dose unless you have an idea about how to get to an effective dose and know what the effective dose that you're shooting for is.
Great, thank you. Next question. As a primary care doctor managing medications, who is evaluating for suicidal ideation and how frequently?
If you're prescribing the medication, you should be monitoring. So when the first warning came out, the FDA had recommended this kind of monitoring schedule of that the kids or the families would be checked in at least once a week for the first 4 weeks, and then every other week for 4 weeks, and then once a month. And it became very difficult to kind of implement that. So, what I do is I tell the parents about this concern about the black box warning and what it looks like. It's not common. The estimates are about 2% of kids would have this reaction, 1 in 50, so it's uncommon. And that, the parents can help monitor, the kids can help monitor. The doctors should be checking in, on a regular, whoever's prescribing the medication should be checking in with the family and make sure the family knows that if they have any concerns, they can call the doctor or a covering doctor on a regular basis. The weekly in-person visits is not practical from a psychiatric standpoint. I'm sure it's not practical from a pediatric standpoint. I think in general the idea is that there has to be some level of monitoring, and parents can do the monitoring as well and alert you to any sort of concern. But the person prescribing the monitoring can be the person. The other strategy is if the kids are seeing a therapist and they see the therapist a lot more frequently than they might see the primary care doctor or the primary care prescribing nurse practitioner, is to work in conjunction with the therapist and let them know they're starting a medication, that we need to monitor them, and sometimes the therapist working with a family who sees them more frequently might help in the monitoring as well.
Okay, our next question is, would you mind going over which SSRI you would start and why one SSRI would be more effective in certain patients?
You know, that's a tough question because, you know, I tend to sort of work with medications. I mean, we tend to make our first recommendations based on FDA-approved medications. And with non-OCD anxiety, you only have one FDA-approved medication for kids, and that's duloxetine. And we never start with duloxetine. We always start with SSRIs. There is good evidence, really strong evidence, suggesting that both duloxetine and sertraline in randomized controlled trials sponsored by the National Institute of Mental Health are effective, safe and effective for kids with anxiety disorders. So I tend to favor, you know, I'm an evidence-based psychiatrist. I tend to favor the evidence, and the evidence is lacking in some of the other medications for anxiety specifically. So I tend to favor fluoxetine. And one of the differences with fluoxetine between the other SSRIs is it has a very long half-life, and that can be a good thing. So if you miss a dose occasionally, it's not going to appreciably affect your serum level. It can be a bad thing in certain situations with, like, for example, with people with very fragile medical problems like fragile diabetes. If the SSRI ends up causing problems with appetite or food intake, and you want to stop the medication, it hangs around literally for weeks. The primary metabolite and the active metabolites hang around for weeks, so it takes a long time to get out of the system. That's unusual for, it's particular for fluoxetine. The others, like sertraline, has a half-life of 24 to 36 hours. So there are some nuances in terms of the pharmacology, the pharmacokinetics, and there is differential information about the medications being tested in kids. So I use a combination of evidence, scientific evidence, and pharmacology in terms of making my initial treatment recommendations.
Thank you. What resource do you encourage parents and patients to use to learn about their medications and side effects to keep them off Google?
So, you know, there's a couple of, that's a good question. There's a couple of good resources. So the American Academy of Child and Adolescent Psychiatry on their website has lots of information about medications for kids, psychiatric medications for kids. Very balanced, you know, talking about the potential benefits with the potential side effects, and they certainly keep the side effects in perspective, whereas a Google search will highlight, you know, every awful thing that could possibly ever happen when you're taking medication. So another good resource for the anxiety is the Anxiety Disorders Association of America, which has a lot of information for the anxiety disorders per se, and also different treatment interventions for anxiety. So those are two really good resources for people about psychiatric medications for kids and anxiety disorders.
Great, thank you. I think that's it for our questions today. Thank you, Dr. Waslick. Thanks to everyone for participating and asking excellent questions. If you have any further questions or would like more information, please feel free to email mcpap@beaconhealthoptions.org, and we will make sure that Dr. Waslick is able to answer any remaining questions. Again, I want to remind you, you're going to receive a very brief SurveyMonkey when you sign off of the webinar. We would greatly appreciate if you could take the time to complete that. And our recording of this session will be available on our website no later than tomorrow. Again, that's www.mcpap.org. And our next clinical conversation will be on Tuesday, March 22nd at 12:15 on managing depression in the pediatric primary care practice. Thanks, everyone.